FLT3 AML is a not uncommon subtype of AML. We see it about in 1/3 of patients, and it has historically been associated with a pretty poor prognosis. Luckily, in the past few years, we've had a variety of FLT3 inhibitors arrive at the market, and we have a lot more in the pipeline. What's next, I think, is really how best to use these agents, kind of in what order and for what population, and learning whether or not it matters which FLT3 inhibitor we give to patients at which time. To try to further that, we have results of the RATIFY trial, which looks at an oral FLT3 inhibitor, midostaurin, in the upfront setting of AML, so the newly diagnosed patients, and adding it to our standard of care 3+7, which we've been very comfortable using for AML for years. I found that trial particularly exciting. While there wasn't a difference in response rates, the overall survival difference between those patients who were treated with midostaurin versus those patients who received placebo was really quite dramatic, especially when you consider that the survival data was censored for those patients who went on to get transplant. So I think this is a really important new agent for us. In the relapsed refractory FLT3-positive AML, I talked about two agents. One that's FDA approved, which is gilteritinib, which was approved based on the ADMIRAL trial and an early look at that data. And another agent, quizartinib, which is being studied in the QUANTUM-R trial with more thorough data to be reported soon, both of which I think might be very reasonable options for clinicians facing a patient with relapsed refractory FLT3-positive AML.